very good morning. It can be a good afternoon or even a good evening, depending on when you are viewing this slide. Today, our subject of discussion is dermatomyositis. This is part of the old MCI curriculum for 8th semester. So we have 6 faculties. We have divided the chapters amongst ourselves. So I will discuss dermatomyositis. So what is dermatomyositis? It's a rare connective tissue disorder, autoimmune connective tissue disease. It's an idiopathic inflammatory myopathy, and the term was coined by Uwe way back in 1891. It has two types of onsets depending on the age. One is adult onset, which is called the classic dermatomyositis, which begins between the age of 40 to 60 years of age, and a juvenile onset, which begins below 18 years of age. There is a slight female preponderance in adults, but this female preponderance becomes very marked as far as children are concerned. So as with any other autoimmune disorder, there are certain triggering factors. One of them is the genetic predisposition. Every autoimmune disorder has a genetic predisposition, and this is substantiated by a HLA-DR3 or B8 association, and it is also seen in monozygotic twins. There are certain infections like bacterial infections, viral infections, all types of viruses which can trigger the onset of dermatomyositis. UV rays, ultraviolet rays, plays an important role in triggering the disease and also in the perpetuation of the cutaneous manifestations. Certain drugs can lead to dermatomyositis like manifestations, especially hydroxyurea after a patient has consumed it for more than 2 years, and when statins, the lipid lowering agents, they can also lead to the inflammatory myopathies. Most important is the association with internal malignancy, which is seen only in adults. Juvenile dermatomyositis is never associated with, has not yet been reported to be associated with internal malignancy. And in case of females, always look for the reproductive organs, the ovarian carcinoma and the breast CA. For males, look for nasopharyngeal CA, and for both the genders, look for colonic carcinoma or even lung cancer or any other internal malignancy. So you have certain classification criteria for polymyositis and dermatomyositis. This is the latest. Way back in 1995, there was an older one, Bones classification, but now this is the classification which is generally being followed. I have given you the reference. You can go through it and see the classification criteria. There are 9 points, so there is no point going through them. So you can see it leisurely later on. The most important is the skin lesions and the proximal muscle weakness, along with the elevated serum creatine kinase or aldolase levels. So you go through this criteria later on. This is Tanimoto K et al. Criteria, which was published in Journal of Rheumatology in 1995. So you can go through this later on. So what are the clinical features that we come across in the classic form of dermatomyositis? Most important is the proximal extensor muscle weakness. How do you demonstrate that? if the patient doesn't complain of, you see certain cutaneous features which point to maybe dermatomyositis. So always ask about the muscle weakness, like ask them to comb their hair, or ask them whether they can comb their hair properly, or there is some form of weakness in the deltoid muscles, and ask them whether they can get up from the squatting position, or you can, if the patient has come to you, you can always ask them to demonstrate, sit down and then get up, whether they can get up on their own. And this might be associated with a muscle tenderness over these affected muscles. So it's called proximal extensor muscle weakness. The next most important cutaneous manifestation is the confluent macular violaceous erythema, CMV, violaceous. This is very important because, and this is seen mostly over the photoexposed sites, as I've already mentioned. So this violaceous is very important because confluent macular erythema you can see in other disorders like SLE. So you have to differentiate that from dermatomyositis. So there is a possible explanation why this the cutaneous lesions, they have a violaceous look. So in one word, you can say this is a Tyndall effect because of the edema that is associated with dermatomyositis. That edema pushes the dermal vasculature deeper, and and the color that you see on the surface is violaceous. So this is very important. Confluent macular violaceous erythema. So this CMV assumes different names when seen over the different body parts. Most characteristic is the heliotrope. Heliotrope means it's a flower. It's a flower which has this violaceous pinkish look, and if this CMV, confluent macular violaceous erythema, if it is seen around the eyelids with or without edema, this is called heliotrope. Next most important is the Gottron sign. There is a similar kind of CMV that you see with or without atrophic keratotic macules or papules. So the extensions of the fingers, over the extensions of the elbows, then over the knees, medial malleoli, so the proximal and the distal joints. This is Gottron's sign. And what are the Gottron's papules? Atrophic keratotic macules, which are seen over the dorsal aspect of the fingers. I will show you a picture. Over the dorsal aspect of the fingers, usually they are atrophic. They are flat top like lichen planus, but they are atrophic, and they have a bit of keratotic look, a scaly look. This CMV, when seen over the lateral part of the neck and upper back, is called shawl sign, as if a person is putting a shawl on his or her shoulder. Over the anterior neck and upper chest, this is called V sign, and if it is seen over the lateral hips, this is called Holster sign. You can remember these, or just for your so this is the heliotrope with periorbital edema that you see around the eyelids. See, there is a bit of swelling and a bit of erythema. See, these color changes are not very evident in our type of skin, the Fitzpatrick type 4 or type 5, really type 3. So this type 4 and 5 skin, and the color changes are not very evident. So this is the shawl sign. See, there is a bit of scaling, a bit of erythema, hypopigmentation over the upper back and shoulders, and the sides of the cheeks. The similar kind of color change, confluent macular violaceous erythema over the neck, anterior neck, in a V-shaped manner. So all these color changes, they are occurring over the exposed parts. So photo exposure is very important, and during the treatment also you should ask the patients to avoid sun exposure as far as possible. So these are the keratotic atrophic macules and papules, the Cotton's papules I have mentioned. In linear streaks, this is very important. See the linear pattern that you see over the dorsum of the hands. The lesions have started from the distal interphalangeal joint and extended to the dorsum of the hands. So this is very important, and the lesions are more marked on the extensors of the joints. They're flat topped, scaly, a bit of atrophic macules or papules. So what else do you see in the clinical features? There can be an extreme pruritus, especially if it is associated with internal malignancy. There are several types of calcifications that we see in skin. It is called calcinosis cutis. There are 5 types, but mostly that you see in the connective tissue disorders like dermatomyositis or systemic sclerosis is dystrophic calcification. This dystrophic calcification is most marked in children. In systemic sclerosis, you find this in adults, but the calcification that you see in dermatomyositis is usually seen in children. Another important prognostic sign is the nail fold capillary dilatation. So sometimes you judge the response to treatment by seeing the nail fold capillary dilatation. Anti-synthetase syndrome. This is a means conglomeration of different clinical features, amongst which interstitial lung disease is very important. Again, nail fold capillary dilatation, Raynaud's phenomenon. There are other features, and this is associated with the anti-cytoplasmic antibodies, the anti-JO1, JO7, 12. So this is associated with the anti-cytoplasmic antibodies, and it has got a means guarded prognosis because of the systemic manifestations like interstitial lung disease. Sclerodermatomyositis. This is part of a overlap syndrome with systemic sclerosis. With systemic sclerosis, mostly what you find, you have heard of the term MCTDs, the mixed connective tissue disorders, so or mixed connective tissue diseases. So there is a propensity to mention overlap syndromes as MCTDs. So that is not the case. MCTDs have clear set of classification criteria along with antibodies to E1-RNP, but all the overlaps are not MCTDs. So remember this whenever you are studying the connective tissue disorders. So sclerodermatomyositis is just an overlap of dermatomyositis with systemic sclerosis, and where you find an anti-KU antibody, and this has got a better prognosis. Now if the other muscle are involved, then you can have difficulty in speech. The vocal cord muscles are involved, drooping of eyelids, you can have dyspnea, myocarditis, conduction defects. So cardiac manifestations are very important as far as prognosis is concerned, and even there can be an involvement of the diaphragmatic muscles. There is a condition called CADM, clinically amyopathic dermatomyositis. That is, clinically you don't have the proximal muscle weakness that we have already discussed. You have only the cutaneous manifestations. So the diagnosis becomes a bit difficult because the cutaneous features are not very characteristic. You don't have any clinically uh, demonstrable myopathy for at least 6 months. For at least 6 months. See, usually the cutaneous manifestations and the muscle disease, they can occur together, or the cutaneous manifestations can begin earlier, or even the muscle involvement can begin earlier. But if the cutaneous features have already appeared, you have to wait for at least 6 months to stamp them as CADM. After that, it's very unlikely that the patient will develop clinically muscle disease, myopathies. So this is a picture of a girl child who had calcification over these sides, upper part of the gluteal cleft and the left gluteal region. So they have ulcerated the calcification, the calcific foci, they have extruded, leaving behind ulcerations. So I've already mentioned about internal malignancy, which is very important. You have to look for this. Any patient, any adult presenting with classic dermatomyositis or even CADM can have internal malignancy, which can begin before the onset of dermatomyositis, can begin even later on. So you have to be very vigilant, or it can begin even at the same time, concurrently. If you have an abrupt presentation of dermatomyositis with muscle disease or without muscle disease, skin involvement, very abrupt onset, think of internal malignancy. And the cutaneous lesions are associated with necrosis also. You'll have a raised ESR, and I've already mentioned the skin or muscle involvement can antedate onset of malignancy or follow it, or can begin simultaneously. So you have to remember this. So you have to evaluate for internal malignancy every 3 to 6 months. So this is very important for the next maybe 3 to 6 years. You have to, or at least 5 years, you have to go on looking for internal malignancy. And I've already mentioned childhood DM has not yet been associated with malignancy. DM and pregnancy. So any connective tissue disorder, especially SLE, dermatomyositis, they have similar kind of outcome. Uh, there is 50% chance of fetal loss and exacerbation of the clinical manifestations of dermatomyositis. The, the lady happens to be pregnant. So in case of dermatomyositis, in case of SLE, if they have sought your advice, always ask them, the woman in the childbearing age, whenever your disease is in the remission for at least 6 months, this is also important for SLE. Always remember this. When the disease is in remission for at least 6 months, they can plan their pregnancy. Then the outcome might be much better. So the differential diagnosis only comes when there are absence of the classical features. If you have the proximal muscle weakness along with the cutaneous manifestations, it's very straightforward. But if it is not so, only presenting with cutaneous lesions, then there might be a few differential diagnoses. As I've already mentioned about SLE, confluent macular erythema, not the violaceous part, only confluent macular erythema. The overlap autoimmune connective tissue disorders I have already discussed about sclerodermatomyositis. So there can be other autoimmune disorders which can be, or autoimmune connective tissue disorders which can overlap with dermatomyositis. Any permutation combination. The different forms of eczemas, because when it is pruritic, especially of the photoexposed sites, there is erythema, there is scaling. So you might think this is a photoexhibited dermatosis, even a photo-induced dermatosis, right? So it comes in the differential diagnosis. And erythrodermas, especially in children, erythroderma, that is inflammation of the skin involving more than 80% of the body surface area. So dermatomyositis is one of the causes of erythroderma, a rare cause of erythroderma, because it's itself a very rare disorder. So it's an even rarer cause of erythroderma, but comes in the differential diagnosis if you happen to have the classical features of dermatomyositis. Now, what are the laboratory investigations? I mentioned about 10 to 12 laboratory investigations. You not go for all of them at a go. So if you have the muscle disease, just see for the serum creatine phosphokinase, CPK or CK, which is the most sensitive and specific marker of muscle disease. Now, if there is no muscle disease, then it becomes again difficult. Serum aldolase is less specific, but it's very useful in childhood dermatomyositis. Always go for the complete hemogram. Yes, uh, it's very important, especially the ESR, which I have already mentioned, is raised in malignancies, internal malignancies, if it is associated to internal malignancy. So you go for the ANA profile and the anti-cytoplasmic antibodies. Anti-MI antibodies, not mentioned about it here because you need not jumble yourself too much with dermatomyositis. So anti-MI antibodies are the most specific markers for dermatomyositis. Seen in very few patients, but it is more specific. If it is seen, then you know you are dealing with dermatomyositis. That is anti-nuclear antibody, anti-MI. Anti-cytoplasmic I have already mentioned because its importance is in the anti-synthetase syndrome. You can go for 24-hour serial urinary creatine levels just to monitor myopathy. Chest X-ray is very important for interstitial lung disease or the internal malignancies if you are looking for, and especially for the internal malignancies, you undertake ultrasonography or CT scan of the abdomen, neck, thorax, pelvis, depending on wherever you are thinking the malignancy might be. Pulmonary function test is important for interstitial lung disease. Now, if you don't want to go for muscle biopsy, whenever you see proximal muscle weakness, you can undertake the non-invasive methods of muscle involvement detection by EMG, electromyography, ultrasonography of the muscles, or MRI of the affected muscles. Skin biopsy doesn't have any telltale signs of dermatomyositis. By seeing this, you cannot stamp them as dermatomyositis. There are a lot of overlap with the other connective tissue disorders like SLE. So, but you can undertake, if you have only cutaneous involvement like in CADM, you have to go for skin biopsy. And ECG and echocardiography becomes very important if you want to detect cardiac involvement, and this is also seen in children, both in adults and in children. So we have already discussed that children, they have a better prognosis as far as mortality is concerned, and it is not associated with malignancy, the childhood dermatomyositis, but because of the chances of vasculopathy and vasculitis involving both the skin and other organs, subsequent calcification can lead to a lot of morbidity in children. In adults, the presence or absence of interstitial lung disease, internal malignancy, cardiac involvement always decides the outcome. And the most common cause of death is respiratory infection. Then comes lung and cardiac disease. And of course, the associated malignancy, if it is in a very advanced stage, then it's also an important cause of mortality. But otherwise, as far as dermatomyositis is concerned, the most important cause is respiratory infection, then comes the lung and cardiac disease. So how do you treat these patients? If they have only CADM, only cutaneous disease, then just ask them to avoid direct contact with UV light by physical methods, umbrella, hat, and all these caps, right? Or even sunscreens. You can prescribe topical corticosteroids, and if it is a long-standing treatment, or we can switch over to topical tacrolimus also, along with antihistaminics as and when required. But when it is a classic DM, which is most important, both in children and in adults, you can start with hydroxychloroquine or chloroquine with periodic eye checkup. But if there is marked muscle disease, there is involvement of other organs, the systemic manifestations, then you have to fall back on prednisolone, which is started at dose of around 1 to 1.5 milligram per kg body weight in adults, and at a bit higher dosage, maybe in the range of even 2 milligram per kg body weight in children. This is very important. For children, you start with a higher per kg body weight amount of prednisolone, and you have to prescribe this for a longer duration of time. You have to wait and see the response at least for 2 to 3 months before you switch over to something else if there is no response, or add something else, adjuvants, as we have discussed later on. We'll discuss later on. So you have to wait, you have to be very patient, right? And if you can, if there is response, then taper very slowly over a period of 2 to 3 years. So it's a long run process. So you have to start with a high dosage and then taper it, reduce it slowly over a period of 2 to 3 years. You can put them off systemic corticosteroids. Important adjuvants, or if prednisolone is not effective, is methotrexate for especially muscle and cutaneous disease. If there is lung disease, then what the chest specialists prefer is azathioprine nowadays. Previously they used to prefer cyclophosphamide, but because of these side effects, it has almost been out of use now. So they prefer azathioprine for lung disease. There are a lot of positive and negative feedbacks regarding the different biologics, like the TNF alpha blockers, infliximab and etanercept, and the CD20 uh, receptor blocker, rituximab. You can prescribe low dose aspirin as you do in systemic sclerosis, just to prevent the platelet aggregation. The biphosphonates like alendronate, they are used whenever there is calcification, or you can even use diltiazem, aluminum oxide. Physiotherapy becomes very important because there is muscle disease, so patient gradually improves with all these medications. So when there is no tenderness, the patient has gained a lot of strength regarding muscles, then you can advise a lot of active physiotherapy. But in the acute stages, when there is muscle tenderness in the beginning, always prefer passive physiotherapy. You have to be very careful regarding this. Passive physiotherapy during the acute stage and active during the chronic stage. So we come to the end of this chapter, dermatomyositis. It's a small chapter. If you have any queries, your CR Shajuti has my phone number. You can call me, or you can even get in touch with because this is a one-way communication. This is not a discussion. This is a one-way communication in these prevailing times. So you can always get back if you have any queries. So thank you very much for your patient hearing.